Hi, welcome everybody. Welcome to this another session for MCQ Live, Medicoapps MCQ Live. Just let me know if you all can see me. There's a comment section, live comment section. You can just put in your comment there, and I will know that I am live. Once I know that, I can actually go ahead and start the session. So this is our session 5 on 25th April. So I hope all of you can see me live. Okay, so let's start today's session. This is 25th at 4:30. So I try to take these sessions in afternoon at around 4:30, or sometimes when I'm not available in the evening, I'll be taking it at 1 o'clock. So again, four sessions are planned for this week. Today, four sessions in a row: 25th, 26th, 27th, and 28th. For anyone who is attending this session for the first time, I'm Dr. Abhishek, your mentor at Medicoapps. Okay, so for anyone who is tuning in for the first time, make sure that you give this video a thumbs up so that it gets stored in your uh, liked video history. If you have any question on this particular session, you can leave it in comment. If you have suggestions or topics on which you want me to, take some, uh, future classes, future questions, then put it in the comment. And if you like this session, please make sure that you share it. If you are new to our channel, make sure you subscribe it. Before I start my today's session, I just want to talk about this daily update. So we send daily update on your WhatsApp. So in this daily update, there will be basically concept cards, so flashcards, which will help you to learn that we send. We send short videos, quizzes, master classes, which means long lectures, and then we also have live sessions. This live session which I'm taking today, similar live sessions, whatever, whenever we are, we will give you notifications. A lot of very important last minute revision PDF which we give, and mini courses. So to join, it's very simple. You can go to medicoapps.org/groups. So it is, I hope it is not being shown. So it is medicoapps.org/groups. Okay, and you can go there and choose any group of your choice and join it. Basically, there is a first year group, second year group, third year group, final year group, intern group, based on your interest area. So with this, let me start our today's session. This is the first question of today: which of the following is or are true about autosomal dominant, okay, polycystic kidney? Okay, so which of the following? So first is, many patient may be asymptomatic till third or fourth decade. Now, so here you are being asked except. So which of the following is actually? So it is true except, which means you have to find the false statement. Remember, so such kind of simple questions also, they can make it complex. So many patients may be asymptomatic till third or fourth decade. So this is a correct statement for polycystic kidney disease. May be associated with hypertension. Again, this is correct, because we know that in adult polycystic kidney disease, what happens is, because there is a cystic dilatation, there will be decrease in the GFR, and this decrease in the GFR will increase your renin levels, and this renin level increase will lead to sodium retention, and this will lead to hypertension. Okay, so a lot of these patients will have hypertension as either as a presenting feature, or when you take a history, and they will give you a history of throbbing headache because of the hypertension. So this also is a true statement. So this is a true. Subarachnoid hemorrhage is the most common extrarenal complication. Now this is clearly a false statement, because the most common extra renal manifestation, can anyone write in the comment what is the most common extra renal manifestation? So you are correct, it is liver cyst. Okay, so liver cysts are the most common extra renal manifestation. Is it clear? So this is true, this is true, only 3 is false, so the correct answer will be 3. Is everybody clear? It is so because they have been asking which is the wrong statement, which is the false statement. So quickly let us take you through the clinical manifestations of the polycystic kidney disease. So the first thing, as it was mentioned in the question, the first thing you have to remember is the age of presentation. So age of presentation is generally third to fourth decade, which means 30 to 45 years. Most of your patients will present in this age group. What is the most common presenting feature? Can anyone write? What is the most common presenting feature? So remember, a lot of these, so when there is a cystic dilatation, polycystic kidney disease, the kidney becomes very, very long, and there are lot of cysts in the kidney. A lot of cysts will actually, there will be an internal hemorrhage in those cysts. Understood? There will be an internal hemorrhage in those cysts, and what will that hemorrhage lead to? That will lead to, pain. So most common presenting feature will be pain. Now, this pain can have quite a few etiology. So, first, I have told you when there will be any bleeding in the cyst, okay, then it can cause pain because your gerota fascia, which covers the skin, maybe will be stressed. Then the next, also, these patients have a lot of stone formation. So even stone formation can lead to pain. But remember, flank pain is the most common presenting feature for your polycystic kidney disease. Also, we know that there will be increased in the UTI instance. A lot of this patient will have repeated urinary tract infection. There will be increase in the stone formation, as I have already told you, but this stone will be urate stones. Okay, normally it is the it is not the urate stones which are very, very common, but in these cases you will have urate stones which are very common. Okay, so urate stones will be formed primarily in these students. Another very important thing is, as I have told you, because they will be decreased in the GFR, glomerular filtration rate, because of the cystic dilatation and eventual destroying of the kidney. So they will be increased in the renin, and this increase in the renin, what is it going to do? It is going to cause sodium retention, and what this sodium retention will do is hypertension. So a lot of these patients may, because of the hypertension, they will have daily headache. Okay, another very interesting, very, very interesting and very important from exam point of view, they have very high instance of renal cell carcinoma. And what is the characteristic feature of this renal cell carcinoma is, these patients, they will have bilateral and multicentric renal cell carcinoma. And the most common variety of renal cell carcinoma in this case will be sarcomatoid type. All this, the single line, so many questions have been asked. Okay, so remember, these patients have increased incidence of renal cell carcinoma, but the characteristic feature of the renal cell carcinoma is it will be bilateral, it will be multicentric, and most commonly sarcomastoid type. Now, these were the renal presentations. Let's talk about the extra renal presentations. Okay, extra renal. So renal presentations, hardly any question you're going to get. Now, most of the question you're going to get in the examination will be extra renal. So one question you already saw, what is the most common extra renal site? Okay, so we have already said that hepatic cyst or liver cysts are the most common, and remember, these hepatic cysts are lined by biliary epithelium. Again, a very important high point. Apart from the hepatic cyst or the liver cyst, where all other cysts form, so they may also have pancreatic cyst as well as splenic cyst. Okay, all these places you may have cyst. So remember, the most common place where extra renal site to be involved will be liver. Okay, then there are some CNS manifestation. Okay, so these patients are very, very prone to berry aneurysm. in the subarachnoid space. Okay, so they are very prone to berry aneurysm, and which can give rise to subarachnoid hemorrhage. Okay, there can also be malformation in vascular supply of the brain, and so there will be higher incidence of arterial dissection in these patients. Okay, so vascular malformation of brain. Okay, overall there will be very increase manifestations of subarachnoid hemorrhage or stroke in these patients. So these are the central nervous system here. Let's talk about the CVS. Okay, so CVS also can be involved. The most common valve to be involved is mitral valve. So it can have mitral valve prolapse. Okay, also there can be tricuspid regurgitation. Tricuspid regurgitation. So these are the CVS manifestation. Lastly, when we talk about GIT, in GIT you can have colonic diverticulosis. So these are the important clinical manifestations of the polycystic kidney disease. Remember, okay? So you have to know the age of presentation, the renal presentation, the extrarenal presentation. Again, a very common question uh, they will uh, they will keep asking is what is the cause of death in these patients, and lots of students will answer renal failure or any renal complication. But remember, the most common cause, and this you have to not forget in the examination, the most common cause of death in these patients are basically causes due to CVS hypertension related complications like left ventricular hypertrophy. So remember, so hypertension related complications will be the okay. I'll take ECG classes, and KP-JAT. So is everybody clear about this question? Any doubt? So let's again see. So about dominant polycystic kidney disease, asymptomatic till third, fourth decade. This is a true statement. This is a true statement. This is a false statement. Okay. And so the correct answer will be 3 because it was asking about which of the following is true except. Okay. Is everybody clear? Let's move to the next question for today. Now, this again is a clinical case. Now, clinical cases, remember, they look difficult, but actually they are much easier because when you make a clinical case, you put in so much information that it is very difficult to miss a clinical case. Only thing is your basic should be clear, your concept should be clear, and clinical cases will you will be very easily doing it. So let's look at this question. So a 9-year-old boy present with several day history of progressive arm and leg weakness. So there is a weakness of arm and leg. Okay, he had a upper respiratory tract infection 2 weeks back. So several day means the history is of just 2 weeks. Okay, the patient is alert and oriented, so there is no CNS related symptom. Okay, conscious oriented, and his has very wide range of BP. Okay, so his pulse is 60 to 140 and BP is varying from 90 60 to 140 90. So this is a classical sign of autonomic dysfunction. So whatever disease is, it is affecting your autonomic nervous system also. Okay, respiratory is 50 per minute. Okay, respirations are shallow with rate of 50 per minute. There is symmetric weakness of face and four extremities. So this symmetric word literally can tell you that it can be, okay. So symmetric weakness, deep tendon reflexes are absent. So again, this is upper motor neuron lesion, okay. Sensations are intact. So what is the most likely diagnosis? Can anyone write in the question, in the comment, what could be the correct answer? Polymyositis, Masthenia gravis, Guillain-Barre syndrome, and transverse myelitis. So we can easily rule out polymyositis because there will not be any autonomic dysfunction in polymyositis. There will not be, symmetric weakness of a. So deep tendon reflexes will not be abolished in polymyositis. So this can easily be removed. Now, why? let's look at myasthenia gravis. Can be So what is myasthenia gravis? Basically, it's an autoimmune antibody mediated disorder, and which involves the neuromuscular junction. And clinically, how does it present? It primarily presents with fluctuating fatigability. Remember, the fatigability or the weakness is fluctuating, so sometimes it may be more, sometimes it may be less. But what is the primary area which is involved? So here, remember, it is ocular weakness, sometimes bulbar weakness. So obviously respiratory difficulty may be there, and proximal skeletal muscles. But again, you will not have autonomic dysfunction here. A very, very important day. You will not have autonomic dysfunction here. And the last is transverse myelitis and Guillain-Barré syndrome. Now, in both of these, we'll have very, very similar clinical presentation, both Guillain-Barré syndrome and transverse myelitis, except here you will have bladder and bowel movement, bowel involvement, and you will have sensory, involvement also. There will be a level, and the patient will say that below this level it's okay, but on this level there may be, uh, impinging pain, or there will be a lot of sensations on this. So this, at least the question points out towards Guillain-Barré syndrome. Guillain-Barré syndrome. Let's quickly look at Guillain-Barré syndrome, and then we will further come to the question. So, what is Guillain-Barré syndrome? So, it is basically an acute progressive autoimmune disorder. And when I talk about autoimmune disorder, primarily it is type 4 hypersensitivity reaction, okay, of the peripheral nervous system. And what happens is that in peripheral nervous system, the antibodies basically attack both the myelin sheath as well as axonal membrane. So in the peripheral nervous system, both the axonal membrane as well as the myelin sheath, there is antibody against both of them. Okay, what is the etiological agent? So a lot of the viruses and COVID has brought this particular disease again to the forefront, where you know COVID-19 virus, Epstein Barr virus, Zika virus, okay, hepatitis E virus, and SLE. All these have been implicated, in Guillain-Barré syndrome. So what happens after the infection? Generally, 2 to 3 weeks after a particular infection, the antibodies. It's an sensitivity reaction to those antibodies, and those go and damage the myelin sheath or the axonal membrane. How does it present? Okay, so remember, let's talk about the clinical presentation. So there will be a history of a respiratory tract infection, okay, and now it starts with weakness or flaccid paralysis, which is ascending in nature. Very, very important, which means it will start with your limbs, and then to your trunk, and then to your arm, and then to your neck, and then diaphragmatic paralysis. This is the classical presentation. So again, it so you will get a history that first there was a weakness in the leg. Okay, so once there is a weakness in the legs, this so the patient was finding it very difficult to walk. Then there was a truncal paralysis. So the back muscles started getting involved. So now the patient is having very difficult to sit. And then there will be arms weakness. This will be followed by diaphragmatic paralysis. So here what is going to happen? He will have starting having difficulty in respiration. So you are having a patient who will be taking shallow breaths because the diaphragm is paralyzed, and this will followed by neck weakness. So neck floppiness can be there, and eventually you can have facial involvement, facial nerve involvement. Okay, right? So this is how it will present, and eventually this will lead to bulbar palsy. Then there even can be autonomic dysfunction, like in this case. And this entire, in this entire presentation, in this entire thing, this is how it will progress. And the entire progression can take very rapidly, generally, within 4 days or up to 28 days. So the progression of symptoms can be 1 to 28 days. Okay, but it will be progressive. Another very, very important thing about Guillain-Barre syndrome is that all these features will be symmetrical, because you have to differentiate it with polio. In poliomyelitis, it will be asymmetrical and descending paralysis. Is it clear? Very, very important point clinically will be generally the bladder and the bowel will be spared. And this is very important because another differential which we are going to consider, in that there will be, not sparing of bladder and bowel. So are you clear how a clinical presentation of Guillain-Barre syndrome will be there? The patient will have some upper respiratory tract infection, and within 2 to 3 weeks he will start having first the lower limb weakness, then the truncal weakness, which means he will not be able to sit properly. Then there will be, upper limb diaphragmatic paralysis, neck floppiness, then face involvement, then autonomic nervous involvement. So it's a progressively, involvement. Is it clear? And very, very interestingly, this entire progression of symptoms will happen, very rapidly, and probably within 28 days of the start of the symptom. But critically, bladder and bowel will be, spared. Now, a very, very important differential. So let's talk about differential. So what are the differentials? So first differential which I will talk about is transverse myelitis. So what are the features? So even transverse myelitis, what is it? So here there is an inflammation of spinal cord which generally develops 2 weeks after some infection. It can be upper respiratory tract or a acute gastritis. So the patient is recovering from the upper respiratory tract or acute gastritis, and 2 weeks after that he will have these symptoms. So again there will be flaccid paralysis, truncal paraplegia, quadriplegia, diaphragmatic paralysis, even sensory symptoms will be there. But here two things is very, very sensory symptoms are very, very marked, which means there can be a radicular pain or lancinating pain or root pain wherever that particular, but at whatever level the spinal cord inflammation is there. So sensory symptoms, are very, very, characteristic of this. And second thing is, bladder bowel involvement is there. Okay, bladder bowel involvement is there in particular. Also, in this case, as well as in your Guillain-Barre syndrome, there will be labile widely, varying heart rate and BP. So heart rate may be getting very slow and then very fast. BP may be falling down and be increasing. So is it clear, everybody? So how do we differentiate transverse myelitis? Remember, by primarily its sensory symptoms and bladder and bowel involvement. Very close, polio. So polio, remember, the paralysis is asymmetric, okay, and it's a descending paralysis. So first upper limb, first limb, and then you know it will go to legs. So descending paralysis. Is it clear? Another very common, especially in very infants, botulinum toxin. So remember, in botulinum toxin, there will be a history of home delivery, and honey would be given to child. Okay, and these child will show primarily symptoms of bulbar palsy. Okay, and will be very high risk of developing pneumonia. So if we see this question now, if you look at this question, so I can easily rule out polymyositis and myasthenia gravis out of these two, because there is no mention of bladder or bowel involvement or any radicular or lanciating pain. So I will rule out transverse myelitis. My correct answer will be C. Is it clear? If you have any questions, you can keep writing in the comment, because then I would love to answer these questions. Is it clear? Right. Let's look at this next question. Diagnostic feature of allergic bronchopulmonary aspergillosis include all of the following except. Okay, your answers are changing pulmonary infiltrate, peripheral eosinophilia, serum precipitants against aspergillosis fumigatus, and occurrence in patient with old cavitary lesions. Okay, so again, this question is relatively old because now there has been a change in the diagnostic criteria of aspergillosis. But let's talk about ABPA, that is bronchopulmonary aspergillosis. Okay, so we know, first of all, many students confuse between two terms, aspergillosis and aspergilloma. Can anyone tell me what is aspergillosis and what is aspergilloma? So remember, aspergillosis is collectively the term name for all the diseases caused by aspergillus, whereas aspergilloma is basically a fungal ball. Whenever there is a pulmonary cavity and a fungal ball or aspergilloma is formed, that is basically your aspergilloma. Now, when we talk about aspergillosis, there are three primary species which you have to learn. One is Aspergillus fumigatus. Second is Aspergillus niger, and third is Aspergillus flavus. Now when we talk about Aspergillus fumigatus, this is what will cause ABPA, especially in patients who have history of asthma or cystic fibrosis. Is it clear? Right? When we talk about Aspergillus niger, primarily it will affect diabetic patient, and it generally causes angio-invasive aspergillosis. Okay, very high death rate. Okay, and the last is Aspergillus flavus. It will primarily cause sinusitis, as well as it produces a toxin very frequently. When this year NEET PG, it was a question, aflatoxin, which is implicated in formation of hepatocellular carcinoma. Is it clear? Now, you have to remember the risk factors. Normally, how does this, aspergillosis happens? So remember, generally what will happen, there will be inhalation of dust, and this dust will have the conidia of the aspergillus, and then it will get infected. But for every person, we will not get infected because it is all around us. So what are the risk factor which predisposes? So we already know. So one will be neutropenia, or any such condition where the body immunity is lowered, like neutropenia or AIDS patient or leukemia patient or cancer patient. So any one of these conditions. And the second set will be, in patients who have TB or COPD or even, diabetes or asthma or cystic fibrosis. Okay, so all these are risk factors. Even in your COVID patients, there was a much higher incidence of aspergillosis, because all the bed sheets in COVID times, the bed sheets and all the other linen were not changed, or the even rooms were not cleaned so frequently. So these the patient's immunity were lowered. So these conidia which were there, they were started infecting the lung of these COVID patients. Okay. Now, having understood, another very important thing which I want to talk about. Another very important thing which I want to talk about is the mortality rate. The mortality rate of these. Okay, so mortality rate, when I'm talking about, remember, this allergic bronchopulmonary aspergillosis, this will have a mortality rate of less than 1%. When we talk about A. niger, okay, angio-invasive, the mortality rate is almost 100%. And when we talk about flavors, which is causing your aspergillosis, okay, chronic aspergillosis, the mortality rate will be close to 50%. So the diagnosis will actually determine the mortality rate. So bronchopulmonary aspergillosis generally will have a allergic bronchopulmonary aspergillosis will have a better prognosis. So how does this patient present clinically? So he will be a known case of asthma or cystic fibrosis patient. But what will he be presenting will be, coughing bouts, coughing bouts. And the characteristic feature of these coughing bouts will be, the patient will, complain of thick tenacious sputum coming out with cough, and these coughing bouts will not be relieved by their usual anti-asthmatic medications. Now remember, these asthmatic and cystic fibrotic patients will anyway be having a lot of pulmonary, infections and repeatedly coming to you. But you know, when these coughing bouts are not relieved by your common, anti-asthmatic medications, or there is complaint of thick tenacious sputum in these patients, then you start suspecting of allergic bronchopulmonary aspergillosis. Also, many a times they may present with shortness of breath, okay, or dyspnea on exertion, such kind of symptom also. Is it clear? Now, there was a criteria that is called as Rosenberg-Patterson criteria, which was used to diagnose allergic bronchopulmonary aspergillosis. It has been a favorite question for so long. I'll just list it down now. Again, it is not very commonly used these days, but let me talk about it. So this Rosenberg-Patterson criteria can be remembered by a mnemonic called as ARTEPICS, ARTEPICS. Let's look at this. So first A is for asthma. Clear? No doubt. The second is R. Now when you do an X-ray, you will have fleeting opacities in the lung. Now this is not very, very characteristic. Okay, fleeting pulmonary opacities. Very frequently you have been asked in examination causes of fleeting opacities in lung. So one is the topic of today, ABPA, that is allergic bronchopulmonary aspergillosis. The second, very common again, will be tropical pulmonary eosinophilia. Then even conditions like fat embolism or even certain parasites, pulmonary parasites may cause this uh, fleeting pulmonary opacity. So this is not characteristic, but yes, it is used as a part of the diagnostic criteria. The T stands for skin test. Okay, so there is basically cutaneous skin test positive for aspergillus. So you do a skin test for aspergillus, and it will come positive. Okay, the E stands for eosinophilia. P P is for precipitin antibodies, which means IgG type of antibodies increased in the serum. I is for IgE. So IgE is grossly elevated. It can be at more than 100 international unit per microgram per microliter. Okay. Then you for C it will be central bronchiectasis, and last S is for serum A fumigatus, specific IgG or IgE. Okay, so this is the Rosenberg Patterson criteria which is used to diagnose ABPA. Apart from the radiological finding of fleeting pulmonary opacities, all the other are still quite there. So when we have looked at, so changing pulmonary infiltrate, yes, it is there in ABPA. Remember, they will very frequently ask you the causes of fleeting pulmonary opacities. So remember the causes ABPA, tropical pulmonary eosinophilia, fat embolism. These are the most important, and even pulmonary parasites may also cause, or certain drugs also can cause fleeting pulmonary opacities. Okay, proliferative eosinophilia, yes, it is also a part of the Rosenberg-Patterson criteria. Serum precipitants, again, Aspergillus fumigatus, again it's a part. Both IgG or IgE precipitants, against this will be there. And the last, occurrence of patient with old cavitary lesions. So now this is not a part of the criteria. Okay, rather the central bronchiectasis is there. So the correct answer here will be D. Any doubt? Let's look at the next question for today, and it talks about uncompensated metabolic acidosis source. So let's talk about this word. So when we talk about acidosis, so we know the normal pH is 7.3 to 7.45. So when there will be acidosis, the pH will fall below 7.35. So there will be a decrease in the pH. So both these options we can easily remove. Okay. Now, when we talk about metabolic acidosis, now whenever, remember, always try to think of the respiratory first and then you will know. So in respiratory acidosis, what is going to happen? The carbon dioxide is going to increase, okay, because the patient is not able to breathe, so there is a carbon dioxide retention and that is leading to acidosis. So it will present with, if the carbon dioxide, so remember this equation, so if the carbon dioxide is increasing, the bicarbonate, okay, the bicarbonate will decrease because all this carbon dioxide will combine with water, form H and H plus ion. Is it clear? All the additional carbon dioxide will combine with H, okay, and will form H and H plus. So bicarbonate will be increasing, okay, in metabolic, in respiratory acidosis, okay. What will happen in metabolic acidosis? In metabolic acidosis, remember, opposite will happen. So there will be a decrease in the bicarbonate, okay. Is this clear? There will be an increase in the bicarbonate because, sorry, because here metabolic may, the primary cause itself is what you call bicarbonate. So there will be increase in the bicarbonate. So correct answer will be C. This will be incorrect. Is everybody clear about this? Okay. Let's look at the next question. So diagnostic criteria for IBS includes all of the uh, above except. So abdominal pain which improves with defecation, changes in the frequency of stool, changes in the form of the stool, high volume diarrhea without infective etiology. Okay, so all these three we are going to see is a part of your IBS. Only high volume diarrhea is never a part of IBS. So let's look at what is irritable bowel syndrome. So IBS, also called as irritable bowel syndrome. So it, what are the other names of irritable bowel syndrome? So it is also called as spastic bowel syndrome or nervous bowel syndrome. Okay, so spastic or nervous bowel syndrome. So what is the? It's basically a functional GI disorder. Functional GI disorder where there is abdominal pain which is present with changes in the consistency of the bowel movement. Is it clear? So there will be abdominal pain along with the consistency of the bowel movement. Pathogenesis generally is unclear, but there are so many things which are implicated in the pathogenesis of irritable bowel syndrome. For example, changes in gut flora, genetics, change in the pain sensitivity or even environmental factors. So the one of the most common etiopathogenesis which is accepted is basically uh, dysbiosis theory. So we know that in our gut we have got firmicutes and bacteroids. Okay, so if firmicutes and bacteroids ratio is altered, so there is a increase in the FB ratio, that is firmicutes and bacteroids ratio. So there is a relative increase in the firmicutes, and what will this do? This will alter the gut permeability, and because the gut permeability will be increased, so there will be increase in the antigen presentation, mast cell activation, and this will lead to formation of cytokinins and inflammation. Okay, so this is one of the most common here. So what is the clinical features with which they will present? So generally the clinical features will be recurrent abdominal pain. Okay, and it should be more than so one of the presenting feature will be recurrent abdominal pain. Okay, abdominal pain. Now this pain should be more than 1 day per week for at least 3 months. Then only you can make a diagnosis towards irritable bowel syndrome. Now remember, it is primarily a disease of diagnosis of exclusion. Okay, so a few things which you have to remember is the pain is relieved after defecation or passage of flatus. So abdominal pain which is relieved after defecation or passage of flatus. Okay. Second is there should be a associated change in the frequency of the stool, and there should also be change in the appearance or consistency of the stool. Okay. So all these three, if they are there, then it should be like at least two of these three should be there. Okay. Now here, remember, the constipation generally is not relieved by here. Okay. So one of the important thing is that bleeding is not seen in these cases. Bleeding is not seen in these cases. You will have blenching, bloating, nausea, vomiting, dyspepsia, but not bleeding in these patients. Okay, and the diarrhea is generally low volume diarrhea, which means less than 200 ml per day. So remember, the diarrhea, even if it is present, it will be a low volume diarrhea, which means less than 200 ml per day. It will never be a high volume diarrhea, and that is why the question specifically asked about it. So even if the diarrhea is there, it is a low volume diarrhea, which means less than 200 ml per, you know, so this was about it. This brings us to the end of today's session. There were some very critical, I think 4 5 super critical topics we discussed here. And remember, whenever I talk to my students, revision is a very big challenge. And why revision is a big challenge is because there's so much information, revision is boring, and even when my students keep revising, they keep forgetting. So what is the solution? So together we have created something called as concept card. Basically, on all the high important topics, we have created image or flowchart based card. And these cards are not just giving you information, but they will ask you some question and then give you the information. For example, if there is a flow chart, so they will not fill the entire flow chart. They will fill the first step, then put a question mark, put a question mark, you think, and then they will show you the next step, and then again next step, and then again next step. So it's more towards active learning rather than passively showing information like others. So this is it, and this brings us to the end. Tomorrow again we have a session at 4:30. So again, see you then. Till then, make sure that you like the video, you put in your comment if you have any comment, share this video, and if you are new to this channel, don't forget to subscribe. Once again, if you want these notifications of these live classes or concept cards or daily short videos or quizzes delivered to your WhatsApp, then you can go to our medicoapps.org/groups and you will be able to join me, and I'll be sending regular updates, which, and because it's like being sent personally, so uh, we do not allow a lot. So only if you feel that you want these notifications, please do join, and we'll be very happy to send you daily updates. Thank you so much, guys. Thank you so much. Let's end today's session. And if you have any comment,